Just,
True. Okay, after such beautiful videos and talks, I'll be talking about something which we all corneal surgeon really fear of. There's a complication of penetrating keratoplasties. As a corneal surgeon, we want our corneal grafts to look clean, crisp, and really good. Patient saying, well, even we want our therapeutic penetrating keratoplasty to look very good. But it's not. Life is not that easy for a corneal surgeon, and we keep seeing things like this. So the aim of this presentation would be to enumerate what complications we can see and what are the possible prevention and their managements. I have divided this thing into three basic. For intraoperative complications, so first would be related to anesthesia. As Dr. Sandeep and Dr. Parsati rightly pointed out, that we should have very good anesthesia. If there is some poor anesthesia, patient is moving eye or pain, squeezing, it makes the life very uncomfortable. And as Dr. Fogla was pointing out, if it is possible under GA, it makes the life really very comfortable. These are the advent of LMA, laryngeal mass anesthesia. You don't even have to give that much medications, and that works really very good. The second would be trephine related problems. Most of it has already been covered. So suppose you get an eccentric host trephination. So as has been shown by Dr. Nagpal, you should mark the pupillary center, and the best thing is just make initial small mark it and see if you have actually your plan is the same what your trephine is cutting. And in case you still get an eccentric, sometime by slippage, or if the you have put too much visco into the AC before starting your trephination, sometimes you get the slip of the trephine. See if it's only superficial, then you can plan another site, or maybe you can take a larger graft if it is permissible. If the host, so one day I wanted to do a 7.5, but now it's 7.5 and I'm suturing with 7. So it's like that is a very, very, very difficult situation, because the globe, it will not be wound tight. So just ensure that you have planned. Suppose your staff has told you that is 7, just check it yourself that it is actually 7, and then only you start. Same host definition first, and then later on donor preparation. So then other could be iris touch or lens touch. Sometimes the pressure is when you are trephining and you're not using suction trephine, manual trephine, you tend to go inside. Your trephine is very sharp. You tend to injure even iris or lens. So ensure that you have gone maybe around 80% trephination, then enter with either side port, the blade, or MVR 15 number. If you injure the anterior capsule during the surgery, of course you'll have to do a cataract extraction with PCIL. Then there would be things which would be host related. Sometimes during the surgery you get excessive bleeding. It's more common when if the patient had some surface disease initially, or there are deep vascularization, it's adherent leukoma, and the iris is stuck on the cornea, so it will tend to bleed. Or during your therapeutic grafts, the iris is really inflamed, there are iris vessels. Or maybe when while doing the surgery you have induced hydrodialysis or cerebral trauma. So it's like you should be anticipating, at least in therapeutic grafts or corneal vascular, you can anticipate that you are going to have more bleeding. In those cases, what you can use is adrenaline drops before the surgery. It's better to avoid adrenaline drops after you have opened the globe, because it will be directly acting on the vessels. So, but you can use it before, so that you get some vasoconstriction and you tend to get less bleeding. There are people who use Avastin just a day before the surgery, in which there is really vascular. I don't know, I have no experience with that. But in case you are having bleeding, you can cover it with viscoelastic substance or dry with the sponge and carry on with the surgery. After 4 sutures, you can inject OVD, and with the viscoelastic generally settles well. Suppose during the surgery you get a PC tear or vitreous prolapse, then of course you'll have to do as Dr. Fogla pointed out, you have to check eye speculum during and ensure there is no pressure on the globe. Keep the IOP low, maybe intraoperative mannitol. And if there is vitreous prolapse, you have to do partial anterior vitrectomy and see whatever space available. And if you can put a IUL, that is always good. Next would be suture related complication. Intraoperatively, yes, you can get irregular tension of the sutures. We can do intraoperative intraoperative, you can see these bias, how good is it, whether it is oval or not, and then you can replace the suture. Dr. Fogler has already told about this. Sometimes you get iris incarcerated in the wound, especially when there is high bulge. So if you have to ensure that when you are suturing, you lift the edge before passing the suture, and if you have detected that the iris has come into the suture, replace the suture. You can, at the end of the surgery, always check wound leak, and if you are seeing there is some wound leak, it's better to change the suture or maybe put some reinforcing sutures. It generally happens because of the unequal spacing, unequal strength of the sutures, but you have to ensure that the wound is very good watertight before you close the surgery. This is another intraoperative surgery which every corneal surgeon fear of. Everything coming out, suprachoroidal hemorrhage. So this is although rare, but it's dreaded, and this is a kind of complication where you can lose the eye. If you have seen it, suprachoroidal hemorrhage, the basic thing is you check if you can why it has happened, control the IOP, maybe intraoperative Mittal, and control the hypertension. The incidence which has been reported is 0.4 to 3.3%. If it has if it has occurred just after the entering the globe and you have not removed the whole cornea, then maybe posterior sclerotomy can help, and digital pressure and drop Mittal. But if you have opened the globe and at that time it has happened, so it will be very difficult, maybe finger occlusion and Mittal. But the idea is to suture as early as possible, or at least 4 sutures, so that after that you can close the lid, give some pressure, wait for some time, and then again start suturing. But the idea is to close the wound as early as possible. Early postoperative, you can see shallow anterior chamber. If there is a shallow AC, check sedals and IOP. So if IOP is low and sedal is positive, of course there is a wound leak and you don't have any other choice but to resuture. If IOP is low and sedal is negative, then maybe there is some ciliary shutdown. You can try systemic steroids. If IOP is high in a shallow AC, check if there is any pupillary block. You might need to do a peripheral iridectomy. If old PI was there and it is patent and still shallow AC, IOP very high, it may be malignant glaucoma, and take glaucoma surgeon's opinion. In early postoperative, you can get graft source junction disparity also. Or wound dehiscence. The idea is to have a very good anterior edge-to-edge apposition. If you don't get good apposition, there is a possibility that the epithelium might not grow over it, and you will have some weird astigmatism. It's better to take the patient again in OR and do a resuturing. Some wound dehiscence, some wound gape, I think you should take care of it as early as possible. If postoperative you see some iris is incarcerated wound, you have to take care of it. Exposed knots. Sometimes you may leave, although you think that all the 16 knots you have buried, and you see on the first day there are 2 or 3 knots which are there. So it tend to attract the vessels, it tend to attract cocci. So it's better to bury it. You can bury it under topical anesthesia even on the slit lamp. But you take care, it's better to do it in OR, because while sometime burying, you might break the suture. So if you break the suture on a first day on the slit lamp, it will be very difficult. So for me, if I see a knot, I take the patient in OR and do burying under topical anesthesia and under microscope. Then you have to ensure that the graft epithelializes as early as possible. You have to be really after it, and your patient should be very frequent to you till the graft epithelializes. Generally it does so in 2 to 3 weeks time. If it doesn't happen, you really have to search the cause. Why the epithelium is not healing? Is he have a bad limbus, or there are some tight suture and one loose suture and the epithelium is not going over it? How's the blink rate? How's the Bell's phenomena? Is there some drug toxicity? Are there any lid abnormalities? What is the limbus status? So you have to take, but you have to ensure that it gets epithelialized. You can use bandage contact lens, autologous serum, amniotic membrane grafting, or tarsorrhaphy, but whatever. You cannot leave the epithelial defect, because ultimately it may lead to graft melt. Sometimes you see a loss of filaments on the graft. All you need to do is preservative-free lubricants. Again, you have to ensure that the surface is stable. You can use bandage contact lens or even tarsorrhaphy. Primary graft failure, if the graft fails to clear even in first month, then basically generally the cause is, if the surgery is totally uneventful, it is possible that the tissue cell count, whatever the eye bank has reported, some cell loss was there during the transport, or maybe it was not the actual specular. So you need to report to the eye bank, and also check if there is any severe hypotony or intense inflammation. Sometimes you can wait with systemic topical steroids and it clears if there are some cells, some good cells there. And then if you are doing therapeutic PK, you have to see if there is any infection in the graft, and there you have to see if it's a fresh infection or it's a recurrent infection. You can see some endoexudates here. This was a first PK, this was a recurrence. Another patient who had undergone therapeutic PK, you can see here, there was some infiltrate which kept on increasing, and if there's an infection, fungal infection in the graft, you have to generally most of the time do a regraft. Late post-operative complications, you can get loose sutures. Loose sutures, you have to ensure that you do a fluorescein stain with all the visit, because you tend to pick up loose suture with fluorescein stain very well, and you need to teach the patient on all the visits what are the signs of loose suture. Tell him he'll get irritation, he should report to you as early as possible, because if you take care of loose sutures early, you might really prevent graft infection or even major catastrophe. You have to remove a loose suture and then either replace it or leave it, depending upon what is the time. Then if there is a loose suture, it can attract infiltrates, and these are the graft infiltrates. Most of the times suture related graft infiltrates are gram positive cocci, but you need to take scraping and treat accordingly. For me, if it's a gram positive cocci, cefazolin generally works very well. If it's non-suture related, there is a recent article who said that the gram negative bacilli or the gram negative cocci can be very common in non-suture related grafts, infiltrates, but you have to see what the exactly organism is and to treat according to the etiology. You can get HSV keratitis, it can be a fresh infection, it can be a recurrence, so you have to ensure that if it's an old HSV, you give good prophylactic acyclovir, sometimes for even lifelong, and this kind of infection can be treated very well with ACV. But if there is any graft infiltrate or any infection, it increases the chance of rejection. You need to teach this to your patient. If you have a graft rejection, most important thing is to pick it up. You see if there are some, as you can see, half of the graft is edematous, half is clear, there's a colloidous line, or sometimes you see a loss of capes on the endothelium. If he has presented before, within 72 hours, you can think of IV methylprednisolone to shut down the immune system. Since it's a systemic process, I personally feel that both topical and high dose topical steroid should be given. Astigmatism has already been talked about, so I'll skip this. You can do a selective suture removal for intraocular. This has already. Any other intraocular surgery like endophthalmitis, CME, globe perforation, and that is almost the same. So these are the basic complications. Thank you very much.